All right, welcome back, and thank you so much for staying with us on the health segment this morning. We are talking about fistula and the country's efforts to eradicate or eliminate fistula. The goal is actually supposed to be 2030. By 2030, we shouldn't be having the same conversations that we have been having over time. The theme for this year, in marking the International Day of Ending Obstetric Fistula, that's usually actually a mouthful for me, is 20 years on, little or no progress. And it is time for us to act now. If I may just quote how I understood the theme for this year, the global marking of this very important day. So it got me thinking, 20 years down the line, what have we achieved? And if you bring this closer home in our country as Kenya, what do we know about fistula actually? And what is it that we have done to end this form of injustice that is preventable, that is affecting millions of women across the world, and in our country, thousands. And I'm having in studio with me a panel of two ladies who will be telling us a bit more about how to get to the vision that we want to get as a country. I'm having this morning on my far right, Nancy-Lynn Kavuka. Nancy-Lynn is a reproductive health expert at Reproductive Health Network Kenya. We really appreciate your time, Nancy-Lynn.
Thank you.
And we have with us, of course, Betty Nduku Kasioka. She's a nurse by profession and a reproductive health coordinator all the way from Thika Town. We also appreciate your time this morning. All right, a conversation that is quite timely, if you ask me. Just a few hours, we'll be marking that very important day. And let me begin with you, Nancy-Lynn, as we look into this year's annual marking of this particular day. What are some of your key concerns, issues that stand out for you as somebody who has been a reproductive health advocate? What are your key concerns when it comes to matters fistula?
Thank you so much for having me. And when we are discussing matters to do with fistula, we are currently also discussing about the high teenage pregnancies, okay? So one of the causes and leading causes actually in obstetric fistula, if I may put it, is that the early marriages, the young people who are getting pregnant before it's due time, it means they're gonna have this complication later on in life or during child delivery. And at this day and era where we are advocating for having this information, sensitization to the young generation outside here and in all the country as at large, that we shall have these discussions from the root cause of it. What is this that is leading us there? It means if we've not achieved it 20 years on, there's something that is still bragging or dragging us behind. Yes.
You know, Betty, I usually never want to assume when we are having these conversations that people know what we are talking about. The essence of awareness is to help people who may not even have interacted with, a particular condition or a particular disease to actually know what it is and how many people are affected. So a basic point to start would be, what is fistula? And she has talked about teenage pregnancy, so we understand it's closely related to childbirth. Take us through what fistula is and how it relates to childbirth.
Thank you very much. To begin with, I would want to say that I'm a national trainer for the female genital fistula. And to define a fistula is an abnormal connection between two organs. And the female genital fistula is whereby there is communication between the birth canal and the rectum, that is where the feces pass, or an abnormal connection between the birth canal and the urinary system. It may be the urethra, that is where the urine passes when it's going out. It may be the bladder, where the urine is stored. It may even be the ureter, where the urine passes from the kidney to the bladder. And a woman who has a fistula, maybe let's call them two types of fistulas, generally a urine fistula or a stool fistula. Let's start with the urine fistula, which is the most difficult and stigmatized kind of fistula. A woman who has a urine fistula leaks urine day and night, 24 hours, on her seat, on her bed, to her legs, everywhere. And that urine cannot be controlled. It cannot be stopped. She doesn't feel it coming out, and it comes out through the birth canal, or what we call the vagina, if I'm allowed to say that. Then the woman with a stool fistula mostly has stool coming out through the birth canal, either because there's a tear or there's a hole that connects the vagina to the rectum.
Mark you, this is reverse. This is not what is supposed to be happening.
Yes. Ideally, the stool is supposed to come out through its normal way. And as we know, the stool, and that is where it comes out through, there is a valve that closes that place, such that when you feel like you want to go for a long call, you'd be able to hold it and go to the toilet, reach, finish your business, and come back. But when these women get the urge to pass the stool, before they reach the toilet, the stool has poured out. Or if the sphincter, which closes that is the mechanism that closes the area where the stool is supposed to come from, is not affected, but there is a hole. Because of the pressure, the stool goes into the vagina, such that when this woman goes to clean herself, when she comes out, she finds that, oh, there's still stool on the front part, and it's not supposed to pass through there. The other one, which is least understood even by healthcare workers, is whereby when a woman sits down, because of the hole that is between the rectum and the vagina, the moment she stands up, the air that went into the vagina and was trapped comes out through the vagina very loudly, and it cannot be controlled. And most women have told me that their children and their spouses have told them they have no manners. But you see, the woman cannot control that.
Control. The key word is she cannot control whatever is happening to her. And that is what people don't understand. No wonder the rates of stigma are still very high in the society. And Nancy Lynn, you know, how common is that problem she's describing for us, the different types of fistula? How regular, even in terms of numbers? In the context of our country, what are we looking at? How many women or girls are affected by this?
Thank you. Globally, it records 2 million women go through this. In Kenya, 3 to 4 deliveries, in 1,000 deliveries, for example, per year, you get 3 to 4 cases of fistulas, okay? And one of the things that really brings it out is the stigmatization, the isolation. We've seen marriages broken up. Partners are leaving because as a woman or as a girl, once you go through the child labor and it's obstructed labor, because that is the cause of it, and once you get this fistula, and we understand currently health is very catastrophic. You can't have that money. And if you check out the statistics, most of these happen where there's inaccessible healthcare facilities where you can have this care, be it prenatal care before you go through the pregnancy period or during. And we've discussed about before the 3Ds, the delays that actually lead to these fistulas, for example, will be delayed to a healthcare facility. You get to the healthcare facility well, but there's no healthcare worker to help you because of the ratio, again, of healthcare worker to the population. So with this 3 to 4 in 1,000 deliveries, that is a lot, and that's a high number. So we get to stigmatization, we get to depression. You can't even take care of this child that you've given birth to if you're lucky enough to have the child alive, because most of them lead to stillbirth, and the traumatization that goes along with it is a long way. Hence, these discussions are very important to create awareness, to have this information out so that women and girls are empowered and they can make right choices way from the beginning.
From the beginning.
Yes.
When you mentioned, you know, a healthcare worker to attend to you, I was going to add, you may even get one, but they are not very skilled.
Oh, yes.
Even in detecting or even handling you. So we may have healthcare workers, but are they skilled? Do they know how to, you know, handle these women when they present themselves to the medical facility? That's also something that we should be focusing on. Betty, I was interacting with some information while prepping for this show, and just examples from the text I interacted with about women who are giving testimonials on their fistula journey. There's one called Ndongo in her late 60s and has lived with obstetric fistula for 37 years. There's one called Jumwa. She's in her 70s. She has had this condition for almost 70 years. I'm looking at the years. What do you read in these years? Does it mean that they don't know, or there is no option, or what is happening? And they are not the only ones. Most of the fistula patients will tell you by the time they got help, maybe these days because of awareness, some get it easy, but long time ago, it used to take years for a woman to actually get help if she gets finally. What do you read in those years?
To begin with, most women don't even understand what's happening to their body. And in our training as nurses and doctors and all the other cadres, clinical officers, the female genital fistula is mentioned in the passing.
Yeah.
It's not something that you really go into and learn about it, how to prevent and all that. No. So a woman may come with an issue, maybe say, my urine is coming out and I don't know what's happening. And so the moment the person in the outpatient department hears that, they send them for a urine test, a scan, an MRI, which will not be able to detect a fistula. 2, peradventure that fistula is detected, the women don't know where to go for help, and the healthcare workers also do not know, because like now in Kenya, we have less than 10 fistula surgeons in the whole of Kenya.
Ask me, I only know of one.
They're almost...
I don't know anyone else.
They are almost 10.
I wish I knew more. Yeah.
They are almost 10. And then those of us nurses who are able to diagnose a fistula, we are just 5 in the whole of Kenya. So we have to go around to every county where there's a camp and teach the healthcare workers on how to prevent, diagnose, and refer for management. But these things also go with interest, because actually every obstetric gynecologist should be able to repair one. But if they're not interested, it is not easy. But there's a lot which is being done, because now the government and the partners that support these issues are going away from the issue of doing camps. Because you do the camp, you go away, the skill is not left. So the way we are going now is every county to train obstetric gynecologists with the help of partners, so that anytime a woman gets that issue, they are able to go to that hospital, get diagnosed, and get managed. Like in Kiambu County, where I work, that system has already started. We did trainings around 3 weeks ago with support from M-Pesa Foundation, AMREF, and Flying Doctor Society of Africa. We were able to train the community health promoters, those are the CHPs, on how to go to the villages and talk to women and be able to diagnose or to query a fistula, then refer them to the healthcare workers. We also did a training for the healthcare workers, that is obstetric gynecologists, clinical officers, nurses, and physiotherapists, and anyone, such that when the CHP refers the client to them,
they know what to do.
Yes. So like what I did the whole of last week is to go around the whole county where we trained people and show them practically on how to do it, because we did the theories in class, now it's the practicals. So the sub-counties that have been able to go, they are now able to diagnose and refer for treatment. And also, there's a plan to do a camp in a few weeks' time in Kiambu County, and in the camp, all those that we trained will come there and be able to be trained to be able to diagnose and treat the fistula.
You know, you reminded me of something. His name is Dr. Hissa. Dr. Hissa is, I once engaged him on the show when we were discussing the same subject on fistula. He's actually the only expert I know in this field. I'm sure there are others, but like you were mentioning, there are still very few. The numbers of corrective surgeries that he has done are overwhelming, if he tells you. It shows how we still have a long way to go in our country. And as much as we are having these cases, how many specialists do we have that can actually treat or even help a patient who is battling fistula? And Nancy-Lynn, I just want you to speak to, this gap, this shortage that we have, even as we observe this International Day. What are some of the policy shifts and even stakeholder engagements that are needed to be able to ensure that, in as much as we are advocating for awareness, when the awareness we are finally attain it and these women present themselves to medical facilities, that we have people and the equipment that they need for them to get the help that they so desire? How do we get to that space, Nancy-Lynn?
Thank you. And one of the things she highlighted is actually capacity building. Yeah. And with Reproductive Health Network, of course, working closely in partnership with the Ministry of Health and other stakeholders and partners in the non-governmental organization space. One of the key issues is capacity building and strengthening, and with equipping a healthcare provider, with equipping a community healthcare provider back in the grassroots at the level where they are able to be trained on, they are able to be mentored. There's one thing with training and there's another thing with mentoring. And right now we will all understand you get to train, but most will prefer to move to the global north because they believe it's much lucrative than back here in Kenya. So it means this training should be consistent with the Ministry of Health, with other partners who are interested in this space, are able to come up, train in all counties, not leaving any, and mostly concentrating in Bundus, I would say, back in the places where are hard to reach, if I will put that, and where they don't have these facilities or they don't have the capacity, actually. You can't have to retain a healthcare worker in such a place. Then what are some of these mechanisms that you are able to put them there so that they provide care to where the affected women and young girls are? Yeah.
Just staying on that point, yeah? If you talk about maternity care and access to the maternity services that women need, because this is where it begins. If you get it right from the onset, then we should be preventing most cases of these fistulas. So where are we at in terms of ensuring that every woman who is bringing life into this world has access to the right services when she needs it? Where are we at?
This is one of the topics that are being discussed, and what other ways, innovative ways, that we can get this information back to the women who need it. We saw the other time we had this mobile clinic initiative by a First Lady, and it was well embraced, and it comes back to the legislatures when they and the leaders in the ministries, when they take power over someone else. If it was an initiative that was started by someone and it's not in continue, so it means that this will be a loophole at the end of the day. So once we get to have these strategies put in place, that we have mobile clinics, we have innovations, communications on how to create an awareness, on how to bring women on board to discuss their own issues, to discuss their own health, have this power and being empowered to have the knowledge and the know-how on how to treat and know when to go for healthcare services at the point of need.
At the point of need.
Yes.
Betty, which group of women is more vulnerable or more at risk, and how are the interventions being curtailed or contextualized to meet those unique vulnerabilities for the specific groups of women? Who is more at risk? If there was once I heard that it's a disease for the poor, it's a disease for those who don't have money. Is it true?
Not really. Every woman is liable to get a fistula.
All right.
But that woman who has the money, because to treat one takes between 65,000 to 300,000. That one can be able to access.
That's the average?
Yes. Around 65,000
to 300.
To 300.
Depending on where you're going.
Depending on what kind of fistula it is.
Oh, okay.
So every woman can get a fistula. And most of the time, those that cannot access one antenatal care, where prevention is supposed to be done by education through such a book. Every woman that is pregnant is provided with this book, especially in the government facilities. And like I always say, after the Bible, this is the second most powerful book. And it's written here, this book is supposed to be read by the mother and her spouse or her person. But rarely do the patients get the information to read this book, because they'll be able to see all the dangers and all the risks and come to hospital. Number 2, they've gone to the clinic, it's time to deliver. Most of them may not be able, like she said, to make a decision to access healthcare in a facility. At times when they access, they don't get the service that they need because we don't have the relevant personnel. Sometimes they'll need a referral to be taken to a hospital where if the baby cannot come out for one reason or another, they can be done a cesarean section. When they arrive there, sometimes there are delays. Either the theater has 10 women waiting, and by the time the chance for this woman to be done a CS comes, the damage is already done, because we know the head of the baby is a bone and the pelvis of the woman is a bone. So when the tissues in between, that is the bladder, the ureter, and the rectum, are pressed into against each other by these two bones, that's where the tissues lose blood supply and a hole is created. So sometimes that is the third delay. Yes, the women are there, but there are very many. Or maybe there's only one theater. And
they have to wait.
Yes, and what we usually say in fistula is that the sun should not rise and set twice before a woman delivers. But most of them will want to deliver at home, maybe with the traditional birth attendants. Others just don't want to come to hospital. Others cannot afford to pay for hospital, or even pay for NHIF, which is now SHIF. Others need someone to bring them to hospital. The traditional things that are there, you have to be taken by the mother-in-law and she's not nearby. But what is happening in most counties, and especially in Kiambu County, the governor has come up with the AFIA insurance, where the client who is needed does not need to pay anything. They'll just present themselves to hospital and they're given all the services, though they don't need to worry about that. So yes, women, any woman can get, including healthcare workers, and because of the stigma, they will not be able to come. Like you said, there's a woman who had 37 years. Last week on Monday, I met a woman who has the urine fistula, the urine that pours throughout, since 1989. 1989. How many years are those?
Oh dear.
Those are like
6 years.
30-something.
Yes.
Almost 35.
Actually, 1989 is the year I was employed. So you can imagine for the whole time that I've been employed, that woman has been pouring urine.
It gets to a point they start feeling like, this is my condition, this is my issue.
Isolation.
And they get used to that isolation and the stigma.
And 90% of their spouses will run away. But this woman who got a fistula in 1989, the husband even brought her for checkup. And that is the importance of having men involvement so that they can understand. Yes. We've even had men who have committed suicide because the house is not habitable. This woman pours urine all over. Another one told me that she used to tell the husband it's the children who are peeing on the bed, because she didn't know what was happening. She thought once you deliver, it's normal to pee. But when the children grew up, the husband asked her, is it still the children? And he walked out. Others have committed suicide. Yes.
You know, this misinformation, Nancy Lynn, do you interact with it a lot? Some people calling it witchcraft, some people calling it, do you interact with this form of misinformation a lot about a populace that has a very big problem at hand, but we are not really understanding what this problem is, or we are giving it names? I'm not quite sure fistula used to be called fistula back then. Maybe until recently, and the awareness increased.
Yeah. Okay, so for Reproductive Health Network, in matters to do with reproductive in the reproductive health space, for RHNK, we have a a toll-free Nena na Binti. So Nena na Binti is a toll-free number that you get to call and air your concerns and air your views. And some will also need consultation. We've had cases where people call and they don't know what to do in their state. And they tell it like it is, that I sleep at night, when I wake up, my whole bed is wet. And I've had this condition for 3 to 4 years, and I don't know where to reach out to. So that is where we come in. And as an organization working in the reproductive health space, creating awareness to this woman, giving them information. Reproductive Health Networks has over 500 healthcare providers in 44 counties currently. So no matter where this client is, we are able to refer to a provider who will help them go through this process. And if some need referrals, we are glad to do it and connect them to a specialist who is able to sort them out in terms of counseling, in terms of helping them with maybe connecting them to these foundations that actually deal with fistula repairs. And thank God they have these campaigns that they do, and they go for outreaches and camps so that they can have, if there is a camp that is upcoming and this client has no idea about the camp, Nena na Binti is able to give them the information on when this camp will be held and where it will be held. So we believe in having this Nena na Binti platform where they call for free, they ask questions, and they're able to be referred to the healthcare provider or a practitioner where they'll be sorted out.
Right. But yes, it's treatable. It's treatable. Let's send that message home. Is it
Fistula is treatable. And the most important thing, that is the missing link in the treatment of fistula, is diagnosis. And what the message I would want to give to all healthcare workers is that once a woman delivers, before they go home, like in this book, there's a place where you're supposed to fill if you have checked for a fistula in the maternity, page 20.
Oh, okay.
Yes. There's a place where you feel about whether you've checked the fistula. And most of the time, the fistula doesn't occur while the woman is in the maternity. There's what we call the pathophysiology of tissue necrosis. That is the time the tissue that is injured takes to fall off. It can take 7 to 14 days. So at 2 weeks, every woman who has had a delivery must or should be told to come back to the clinic. And not just to come back, they should be given the reason. The same page 20 of this book talks about what is to be checked, and fistula is one of them. And the message I want to pass to the healthcare workers is kindly, when the woman comes, ask, look, and touch if need be. And I always tell them, and I even put my number.
Don't take anything for granted.
Never take anything. Kuna shida nini? They don't know whether there's a problem.
You check it for yourself.
So I always say, ask, look, and touch if need be. We put if need be because sometimes the woman will just open her legs and you'll see that the birth canal and where the stool is supposed to come out is one opening, which looks like, what figure is this? The diamond figure.
Yeah.
Yes. You won't need to touch that. You'll only need to see
and confirm this.
So if you ask, the woman will tell you the symptoms. Then you look. And if you can't see very well, you'll be able to touch. That is within 48 hours of delivery, 2 weeks in the postnatal clinic, 6 weeks in the postnatal clinic, and up to 6 months. 4 postnatal clinics. But the problem is that, and I hope that will improve, people will be asked questions, or rather women, but our healthcare workers will not look. So if you look, you'll send them for all those things I talked about. That is the scans, the urine, the stool tests, and those ones will not diagnose fistula. I had a woman who got a fistula in 1982, and we repaired her in the Embu camp in 2018. And all the times she had that fistula and went to hospital, no one ever looked at her. No one ever checked what's happening to her. And she was pouring urine all the time. The husband could not stand that. He committed suicide. So she comes from Kiambu County. So she the family had a meeting because she was married, got that pregnancy complicated. She was done CS, and out of the CS is where the fistula came from. So she was returned to her parents' home. When she went home, she was not allowed to go into the house. The brothers, sisters, the mother and the father had a meeting, and they said, we cannot allow a kikojozi, they called her kikojozi, to enter the house. So they deliberated and decided that they're going to build her an iron sheet house near the river, so that when she urinates, the urine can go into the river. So she stayed in that house from 2018.
Is it 88 or 82?
1982.
82.
Up to 2018. When a neighbor who bought a shamba nearby heard her story, and she went there and carried her in her car up to Embu, where we had the camp. So the moment she came to the ward, I asked her to sit, and she told me in Kikuyu, the first thing you must know is that I don't have friends. So I asked her, why don't you have friends? It's because I stink. So I hugged her and told her, no, I'm not your friend. We put her in the list. 14 days later after the surgery, I come in the morning to see her in the camp, and she tells me, Tamaka in Kikuyu is just worry. I'm not pouring urine. Because
she's surprised.
But yeah, she's surprised. Pouring urine was her way of life.
Yeah.
So she got surprised, and then of course, she was discharged, came home. I continued seeing her. And 2 years down the line, she passed away in her sleep, but dry.
Wow.
Yes.
And you see, we want to hear more of such stories of women who had their dignity restored, courtesy of the interventions that have been put in place, Nancy Lynn. But then how do we get to that space? When I was beginning the show, I talked about the theme for this year. I interacted with it. 20 years on, progress, but not enough. Act now, end fistula by 2030. Let's unpack this theme. How do we get to the next phase of the 20 years and actually begin to realize progress and fast enough to save the life of a woman who could be watching this show this morning?
And this progress will start as early as dealing with young adolescents, the youth, yeah? That's where we start from. They are the generations for tomorrow. And beginning discussions with these 20 years, we don't want to have such a discussion in 40 years and keep saying 40 years on, 60 years on. So it's just a narrative all through. And when we come to dealing with reproductive health care network at the base of a young adolescent, a young girl, a young mother, and one of the things that we put across as reproductive health network is having more of campaigns. For example, there's a campaign that is running currently. It will run for 3 years, spearheaded, of course, by Reproductive Health Network with the Ministry of Health and other partners. And this campaign is Chaguo Mkononi, and the slogan is having a woman make the choice, okay? And making a choice in the sense of having this woman, having this information, having the knowledge, okay, and able to make decision. We're saying that health is autonomy. So the Chaguo Mkononi is actually giving out ideas to a woman and advocating for you as a young person that when we are discussing obstetric fistula, we've had data, and data does not lie. We get data from the whole country, and this data is actually used in informing the partners and even the government in making strategic partnership to make some of these policies and what we have in the country. And one of the things we notice is you can even have a 9-year-old delivering at home alone, or this 9-year-old, depending on a traditional birth attendant back in the grassroots level. So when we talk about this initiative, dragging in self-care, that was spearheaded by WHO, and we have the guidelines, Reproductive Health Network, we are glad to have an ambassador who's actually championing it. That's our AD. So these strides are to actually help these women back in their home, at the comfort of their home, that they can be able to delay that pregnancy, okay? And the moral of it is actually to have either delaying the unintended pregnancy, one, or delaying the time at which you're going to have this pregnancy. Having this capacity building and training across from the healthcare providers to the community healthcare providers, we are telling them, don't be judgmental when a young woman, a young mother walks into facility. They should be having this right to able to access healthcare services without fear of discrimination, without fear of being judged who they are. Because when we delay this, then it means we're able to get a healthy mother at the end of the day, at the right time, where your tissues, your organs are very ready to accommodate a growing fetus in your uterus. And one of the things that also contributes to this obstetric fistula is that you have a mother who is 14 years, they've delivered a child, 4 months later, they are pregnant again. The body, physiological of the body, is not even ready yet to carry another baby. That is where we champion in with family planning. We've launched recently where we get to train healthcare providers in the counties level. We've gone to Bungoma, we've gone to Samburu, we've gone to Isiolo, and the advocate is having a self-injectable for these women. If you're looking at the geographical setting, they're not able to get there, then why don't we train them so that they can have their choice in their hands to be able to make decisions?
All right.
Yes.
Quick thoughts I'm getting from your sentiments there is that what we need is actually access to high quality, services. We also need professionals who are trained to be able to deliver these services, and at the very least have access to contraception when need be, so that we can be able to save the lives of women when we can, if that is the only option we have to use. And I'm also getting a feeling of us going beyond just addressing fistula as the only issue. I'm looking at issues that are tied to it, like early marriage, like female genital mutilation, right? Let's talk about those, because we cannot win this war if we don't open this box and open this wound and actually address it for what it is. Betty?
Yes, the mainstay management of the female genital fistula is prevention. And the one most important aspect of prevention is nutrition. Nutrition from the time the mother is pregnant up to the time she delivers the baby, breastfeeding that baby for 6 months exclusively without giving any other food or water unless prescribed medicine, and feeding the child as stipulated in the mother-child booklet. If you see page 41, like I told you, this book is very powerful.
Yes.
It gives you information on how to feed this baby up to 5 years. And then from there, the baby can take the food that's being eaten by the other adults. Because if we do not do this, our women grow with contracted bones, and especially the pelvis. You know, the pelvis, that is the pelvic girdle, is where the baby passes through when they are being delivered. If they do not feed well from the word go, it will be small. The baby will be big, and the baby will not be able to pass. And if they don't get a diagnosis of a big baby and a small pelvis in good time, they develop a fistula. Number two, we need to prevent by empowering our young girls to go to school and be occupied in school, such that they will not have time to go around doing other things and being idle and getting pregnant. Again, we have harmful practices like you talked about. There's the female genital mutilation, which is happening in a few counties in the country. But there are also other harmful practices, like in Northeastern, if a woman reports to the parent or to a caregiver that she has a vaginal discharge, they take a metal rod, put it in the fire, and when it's red hot, the woman is held by several people, and that rod is inserted in her birth canal to burn that place, which is...
What do you even mean?
Yes, to burn that place, which is bringing a discharge. And that's how they get fistula. And then again, if we talk about the FGM, is that when those women are cut, they get a scar tissue. Scar does not stretch. So the moment they go to give birth, it bursts open. And I've talked to some TBAs and asked them, what happens when these women deliver and they get tears? And they tell me, then the subsequent deliveries will be easy. So I ask, what about her cleanliness and her husband? But no, they will deal with that after she's through with delivery. So people do not understand.
What is going on? Yeah.
Yes, number 3, prevention. We need hospitals and clinics, private and public, to have equipment and adequate staff. Because like in our maternities, there's a tool that we use to monitor labor and know when labor is getting obstructed or when there is danger. It's called the pantograph. But at times, the few midwives on duty, if there are 2 by any chance, because most of the time it's 1,
yes,
worldwide, has 5 women who are pushing babies and another 10 whose labor is supposed to be monitored.
And forceful, yes.
And it's not possible to monitor that labor and know whether danger is coming or not.
Yeah.
So
it's overwhelming.
It's overwhelming. Yes, the midwives and the nurses want to work, but sometimes it's not possible. And I think our clients have a lot of faith, especially in our public hospitals, so they flock there. Again, in times like we had the doctor strike the other day, and the clinical officer strike is going on. Most women were delivering at home because they are not able to go to private hospitals. But like in my sub-county, which is Thika Town sub-county, like I had 5 cases where the women from the slum, I don't know whether you've heard about Kiandutu slum, had obstructed labor, and they didn't know where to go. But I talked to the private hospitals. We have the public-private partnership. I talked to Avenue Hospital, Vineyard, another one called Caritas, and they were able to do cesarean section for these women without charging a shilling. So PPP also helps a lot.
But how would they deliver in hospital, these women, if, I'm looking at page 16 of the standard, the provision for free delivery services is now quite... we don't know the fate of that, because according to what the paper is saying, the budgetary allocation is proposed to be cut by half. Free deliveries under the Linda Mama budget. In the proposed 2024-2025 budget estimates, the allocation is going to be reduced from 4 billion to 2 billion. This is something that is making MPs very angry. I don't know how you feel about it. I'd like a cocktail of both your responses on that. Let me start with you, Nanceline.
Reducing?
Do we have more than we need, from 4 billion to 2 billion in the next financial year?
And when it comes to healthcare and allocation, the budgetary allocation, when we talk about guidelines that stipulate we should have at least 7% of the total finance bill to be allocated actually to healthcare. Now, when you have this shift, it means we're already losing it at some point. At this stage, we are still talking about having enough healthcare workers at the facility to help these women when they walk in. Not that you've gone for these women back to where they are at their home. You are expecting them to come in without creating awareness, if we'll say. So if we are actually reducing this, it means we are losing it focus, and it will still be a story of 40 years down the line. We are still talking about fistula and how to fight about it. And it will be so unfortunate, even when those funds are disbanded, there will be misappropriate in some factors. Then we don't have the interest of a common mwananchi at the end of the day.
This was introduced for that vulnerable woman we were talking about.
Yes.
Are we reversing the gains suddenly? Are we suddenly having more than we need in allocating funds for mothers who cannot afford to give birth in hospital?
I think all the other governors should come and benchmark in Kiambu County, because everyone is taken care of. Our governor, His Excellency Wamatangi, has come up with Kiambu Afya, such that if a person cannot afford healthcare, his government has paid to NHIF, this is SHIF. They are registered by the CHPs, such that they'll just walk in and walk out without having to pay a shilling. Those that can pay for SHIF or any other insurance can do that. But that woman who cannot afford to pay for SHIF or NHIF or whatever they call it, is taken care of in Kiambu Afya. If all the other governors took that path, it would take care of the vulnerable women. Yes.
All right.
And again, fistulas have formed every day, even as we speak. A fistula is being formed. But the main problem is we have very few surgeons who can
perform corrective surgeries.
I want to call upon our obs-gyn to just take interest and agree to be trained, because there are partners who want to train them. They take around 5 to 6 weeks to be thoroughly trained on that. So I would call upon our obs-gyn to agree to be trained so that we can be able to help our women. Because yes, we will diagnose like we are doing now, but who will repair them?
All right.
Like the class where I trained to be a trainer of trainers for fistula, we were 22. And of the 22, I'm the only one who is doing advocacy. The rest lost interest. So let us gain interest, because anyone can get fistula. I even have colleagues who've had fistula. I had one last week, but one, I'll not mention the name, and she had been living with a fistula for 14 years. But she didn't find it in herself to be able to talk about it. So stigma is what is killing our women.
All right. We have very little time for this conversation as we mark the end of it. Nancy Lynn, your final words?
Advocacy is one of the key areas that Reproductive Health Network actually spearheads in creating awareness and having a platform where we can be able to discuss some of these issues. And one of the interests I had mentioned is actually the comprehensive adolescent, youth, sexual and reproductive health rights. This year we'll be having our 7th annual conference, and it will create a platform where we'll have leaders in the same room. And key aim is to actually get some leaders accountable, that we have this data, what are we doing about it, how are we dealing with some of these issues when it comes to the dealing with youth, dealing with early marriages, dealing with family planning issues. And the theme is actually to advocate and advancing in adolescent sexual and reproductive health rights. So this information needs to get out there. We'll have over 200 delegates, and it will also be with partnership with the Ministry of Health. We'll have the Director General of Health in the same building. So it was to create a platform where we have to discuss this root cause and get it to the right leaders. As she had mentioned a while back, that you have a governor, for example, who has keen interest in healthcare. 5-year terms are over, someone else come and he's marching to economics. Someone else come, and all the plans that the first governor had are washed into drain. You see in Kakamega County, is it Oparanyake or what was it called? So right now you'll still have no alignment, because the upcoming leader,
they come with their own vision.
They come with their own vision. They dilute it.
Right.
So if you don't have enough people to advocate and as women stand up and get to discuss issues that are really spearheaded in this county.
All right. Thank you so much, Nancy Lynn Kavuka. She's a reproductive health expert at the Reproductive Health Network Kenya. We also been having a conversation with Betty Nduku Kasioka, a nurse and a reproductive health coordinator from Thika Town, Kiambu County. Asante sana, ladies, for creating time for us. And I believe you now know what you need to do to save yourself if you're a woman, or save a woman next to you, from going through this particular issue that we're saying is actually preventable. And if you have fistula and you've been watching this program, there is hope. There is treatment out there. Reach out to the nearest health facility. You'll be guided on where you can be able to get treatment. There are camps that are actually held around the country. Some you don't even have to pay for, and you'll be able to restore your dignity. My name is Safina Chengoma, and that's how we wrap it up. We'll be doing this again next week on the health segment. For now, have a lovely day ahead.